name is Esther Wu. When I was in high school, a good friend of mine that I had known for about 6 years had one day admitted to being a victim of self-mutilation. She had revealed this to me because I had noticed and asked her about a scar on her leg. She had said that it was not a frequent activity, but it was serious enough to have found a need for treatment. She revealed several more scars to me that day and explained how close she came to rupturing a vein. My friend is only one of many adolescents who practice self-injury. According to an article called Self-Mutilation in Adolescence, found in the Journal of School Nursing, there are two types of self-mutilation. The first is culturally sanctioned, which is based on rituals, traditions, and practices that reflect beliefs and symbolism of a society. The second, the more common one, is pathological, which is deliberate, deviant destruction of the body without intent to end one's own life. This pathological view is broken down into three categories. The first is called major, which is extreme, infrequent, serious tissue damages such as castration and limb amputation, which is associated with psychosis and some sort of acute intoxication. The second is stereotypic, which is a combination of repetitive, rhythmic patterns, including headbanging, eye gouging, self-biting, which is seen in Tourette syndrome or with institutionalized mentally ill patients. The third and the most common is the moderate or superficial, which are behaviors resulting in self-destruction of body tissue such as skin picking, hair pulling, burning, carving, and the most frequent, which is cutting. Cutting is the most common behavior seen in adolescent population today. In this article, statistics show that in 1998, it was estimated that self-mutilation affected 1 to 2% of adolescent population, with cutting and burning as the two most common behaviors. In 2003, out of 231 urban students and 209 suburban students, it was noted that 13% of the urban and 15% of the suburban students were classified as having self-mutilated before. In 2004, a sample of 390 students of an urban school, 15.9%, or 62 students, were classified as having self-mutilated before. Self-mutilation seems to be a big issue with today's adolescents. According to an article in USA Today, a 16-year-old high school student revealed in an interview that she knew several students who cut themselves for several different reasons, such as stress from studying, neglectful parents, and relationship issues. So why do these self-injurers want to feel more pain by cutting when they already have these emotional pains going on in their lives? Well, in a health article, a psychologist and psychotherapist named Gunborg Palm indicated that morphine-like substances are released in the body when we cut ourselves. These substances act on the reward center in the brain to suppress feelings of distress in similar ways as narcotics do. According to a journal article called The Truth About Self-Injury, Rebecca Gillingham indicates that self-injury is not done to be cool or to fit in with the crowd. To self-injurers, self-mutilation is a faulty but effective coping mechanism. In conclusion, I would like to say that the rate of adolescent self-injurers is rising. Teens have been turning to such ugly behaviors as a way to cope with stress in various forms. Thus, it is evident that self-mutilation is a major issue in today's adolescent society. Thank you.